Hello, I'm Dr. Joseph Goldberg, Clinical Professor of Psychiatry at the Icahn School of Medicine at Mount Sinai in New York. I'm here to speak with you about an article our group recently published in the Journal of Clinical Psychiatry entitled A Systematic Review of Complex Polypharmacy in Bipolar Disorder, Prevalence, Clinical Features, Adherence, and Preliminary Recommendations for Practitioners. This was a study that was spearheaded by an early career group of psychiatrists in our program, Drs. Anna Kim and Lisa Salstein, and I'd like to tell you something about what motivated the research and what the main findings were and where we go with it from here. So my own background has long been in clinical psychopharmacology in bipolar disorder. In clinical trials over the years, we've witnessed a growing number of medications that are being used in bipolar disorder, initially as monotherapies, in clinical trials sometimes as combination therapies, and in the course of our work, it became increasingly apparent that many patients actually take more than one or even two medicines in bipolar disorder, and that far outpaces the evidence-based literature in terms of randomized trials or even observational studies to help guide thinking about what are the outcomes we might see in people that take, say, more than two pharmacologies. We coined the term simple polypharmacy to refer to two psychotropic drugs, and complex polypharmacy to speak to three or more. So with that background and context in mind, let's talk about the main findings from our study and what we think the implications are. In our survey of the literature, we looked at over 4,000 articles, ultimately deciding on about 50 that seemed to be informative for telling us about the incident rate of complex polypharmacy as well as the clinical correlates. What do we find? We found that about a third of people, adults with bipolar disorder, were taking 3 or more psychotropic medications. A little over a fifth, 22% were taking 4 or more psychotropic medications. And these are observational studies, so they didn't really allow us to ask prospectively, do people do better or worse as a result of taking more medicines? It really just told us more about correlation. So who takes complex polypharmacy in people with bipolar disorder? We found complex polypharmacy was more common in women, in people over age 50, people who were white, people who had a history of psychosis, people who were given subtherapeutic doses of medications, and patients with a higher burden of depressive illness. I want to speak especially to the last point because there's much controversy about how to treat depression in bipolar disorder, and one of the earlier inspirations for this study was some work we had done in the NIMH STEP-BD program, showing that in the STEP-BD cohort, which was one of the studies that we looked at in our own meta-analysis here, having many depressive episodes was a predictor or driver of extensive polypharmacy. Or put another way, if depression is really hard to treat, clinicians may be more inclined to just use a lot of medicines. Whether or not they're efficacious becomes a separate matter. Common to see extensive polypharmacy, more often a correlate of more complex disease states such as psychosis or higher depressive illness burden, and not necessarily reflecting optimized dosing. So let's say takeaways from this would be that when clinicians are contemplating complex polypharmacy regimens, they may want to be very thoughtful about adequacy of dosing in trials before adding additional medicines. We came across combinations that were not always necessarily logical. For example, in patients with mania, retaining an antidepressant would be part of a polypharmacy regimen, but not necessarily make sense. If someone's manic, they don't really need to take an antidepressant. Or duplicative mechanisms, such as combinations of antipsychotics where it's not entirely clear that there's an added benefit of 2 versus 1, especially if one is underdosed. Also raises implications about adherence. It's much harder for patients to stay adherent to a more complicated regimen than a simpler regimen, and we know that poor adherence to psychopharmacology is one of the biggest risk factors for relapse in people with bipolar disorder. And lastly, we really do need randomized trials, or at least more systematic studies that are looking beyond simply the effects of 2 drugs versus 1. If in the real world, 1 out of 3 patients is taking 3 or more psychotropic medications, at least to give us some greater sense of understanding about the safety as well as the possible clinical outcomes for our patients who find themselves taking very extensive polypharmacy regimens. For more information, please have a look at the actual article itself, published in the Journal of Clinical Psychiatry in the May-June issue 2021.